This is a very interesting and difficult case where a patient has developed sclerodermatous changes of the skin, muscle and joint pain, as well as dry eyes and vaginal dryness. So all of these symptoms would be consistent with chronic graft-versus-host disease. And the treatment options are many. One would be oral methotrexate. That has been helpful in patients who have joint pain, for instance, in particular. Another option would be imatinib. That can be helpful in patients who have sclerodermatous changes. Ibrutinib is FDA approved for treatment of chronic GVHD, and ruxolitinib has also been shown to be effective in clinical trials for treating patients with chronic graft-versus-host disease. So I think there are multiple treatment options for this patient, and it can be difficult to know what would be best in a given individual. And I think we need further studies with randomized trials to be able to answer this question definitively. Ibrutinib and ruxolitinib are choices for managing this patient. I can't necessarily say which one of those drugs would be best. I have more experience with ruxolitinib. I think the side effect profile of ruxolitinib might be a little better than what you experience with ibrutinib, but I think both of those would be potential choices in the treatment of this patient, and I don't think we can say for sure which would be the best choice. I would generally start this patient on 1 milligram per kilogram of steroid therapy, and does more aggressive starting dose improve outcomes? I think that's a question that we don't know the answer to for certain yet. And we need further trials to be able to answer that question definitively. Certainly, there are side effects from high-dose steroids. Patients who are treated with chronic GVHD with steroid therapy tend to have a longer duration of treatment. I generally look at a variety of different factors in determining which dose of steroids I would start on a patient. So, for example, do they have thrombocytopenia, which is a negative risk factor? Do they have a significant eosinophilia, which is a negative risk factor? What's the total body surface area that's involved with sclerodermatous changes? So if they appear to have more organ involvement, more severe form of chronic GVHD, then I would generally give them a higher dose of steroid therapy. And with chronic GVHD, we tend to do a more prolonged taper. This patient is developing sclerodermatous changes, and the patient is also developing dry eyes and vaginal dryness. So there are topical ointments that should be applied to both the vagina and the eyes to help with the dryness. And in regards to the sclerodermatous changes, physical mobility is very important. So involving physical therapy, teaching the patient exercises so that they can continue movement as much as they are able to is an important component of the management of this patient. And also sticking to a daily exercise routine for the patient. Avoiding sun exposure that can worsen GVHD symptoms, also increase the risk of skin cancer, for which patients who receive an allogeneic transplant are already an increased risk. The patient can wear protective sunscreen when outside. This would also be an important component of their management.